a multidisciplinary approach. Now, I invite Dr. Gunasagar Das, who was the professor and HOD ophthalmology and ex-superintendent Bhimsar Burla.
Dear friends,
Over to Dr. Gunasagar Das, sir.
Dear friends, I welcome you all to this virtual podium, and I start this webinar with a mantra from Rig Veda, the song of universal unity and peace. Sangachadhvang, Sangbadadhvang, Sangmo Manang Sijanatam, Deva Bhagam Jatha Purve, Sanjanana Upasate, Samanu Mantraha, Samiti Samani, Samanam Manaha, Sahachittamesham, Samanam Mantrang Abhimantra Eva, Samanena Go Abhishajuhomi, Samaniva Akutihi, Samana Hudayanivaha, Samanamastu O Mano Jatha Su Sahasati. Om Shanti, Shanti, Shanti. Let us move together. Let us talk together. Let our minds be in harmony. Let us accept the prasad as deserved. Come on, be our prayer. Come on, be our mind. Come on, be our heart. Let us be happy together. Peace to all, peace to all, peace to all. My dear friends, with this Vedic mantras, we come to the webinar, and we have got two eminent persons as honorable guests to this webinar. First, Professor Anita Panda, the ex-professor and HOD of ophthalmology, Dr. Rajendra Prasad Ophthalmic Institute, AIMS, New Delhi. She is widely known throughout the world as an eminent cornea specialist, and she has attended and she has many deliberations and she has many papers published in national and international journals. I welcome you, madam. She was our past AIOS president also. And our honorable guest is Professor Lalit Meher. He is the director of Bhimsar. He is an academician at par. He was the best graduate of his batch in UG and VSS Medical College, Burla. He is the recipient of WHO Fellowship in Endocrinology. He was professor at HOD, Department of Medicine, MKCG Medical College, Berhampur. He is the founder, dean, and principal, Bhima Bhoi Medical College, Balangir. Now, he is the director of Bhimsar, Burla. Welcome you, sir. Next, we pray to the departed soul of our members in OSOS and IMA for as a silent token of honor, as a silence for 1 minute. Okay. So dear friends, now we are going through a pandemic of COVID COVID-19 since last 2 years. And this COVID-19 virus is changing every time to a new constitution and new symptoms, signs, and new clinical features. Our scientists are working hard day and night to invent new vaccines
Mama,
to prevent
friend,
this COVID. But still this COVID-19 has not been controlled fully. We, the doctors, the physicians, we must know the updates of this virus, and so that we can give service to our patients and prevent this pandemic. Thank you. Next, I hand over the mic to Professor Dora.
Respected dignitaries on the dais and all the participants who have joined us today's webinar on COVID-19 update and multidisciplinary approach. As all of us know, COVID-19 is it is a new type of entity, and we are dealing with this since last 1 year, and the concept of its pathogenesis, treatment, complications, all has been changing with the better understanding of the disease. So hence, today we have organized this webinar in collaboration with Orissa State Ophthalmic Society, in collaboration with IMA Sambalpur branch, IMA Burla branch, and OMTA Bhimsar. And, let us have a very good discussion on this with the active participation of all of you. Now, I invite Dr. Professor Anita Ponda Madam to address the gathering. Madam is there? Hello? Madam is there? Sorry, I think it's not here. So now I invite Professor Lalit Kumar Mehr, our director, to address the gathering.
Respected Chairperson Professor Gunasagar Das, President of Odisha State Ophthalmic Association, Professor Jayashree Dora, Dean and Principal of BSS Bhimsar Burla, esteemed guest of honor Professor Anita Panda, members of Burla IMA and Sambalpur IMA branch, all the esteemed speakers, panelists, and participants. A good evening to all of you. You all know that the first case of COVID-19 was detected in China, Wuhan, that is in December 2019. And soon after that, it spread to around 215 countries all over the world. And it has posed a great challenge, really serious threat to the public health aspect of all the countries throughout the world. It has already, and on 11th March 2020, WHO declared it as a pandemic. Till now, somewhere around 40 crore people throughout the world has been affected. Around 20 crore people in the world has been affected, and about 42 lakh people have lost their lives. And in our country, around 3.17 crore people have been affected, and somewhere about 44.1 lakh lives have been lost. So this is the magnitude of the problem, and I think it is again going to cause also more devastations still, because we have not got rid of the pandemic. Scientists have been working day and night how to curb this menace. There have been a lot of understanding increase in the understanding of pathogenesis and the behavior of the organisms. Accordingly, the guidelines have been changing, the drugs have been changing, and so we had to update our knowledge in this on this subject. So it is the right time, and at this juncture, the IMA has organized this webinar, which will be very, very useful to all of us. Thank you all very much.
So I
Now,
think,
over to Dr. Sarmishta Behera.
thank you, ma'am. I think we'll start the program right away. Dr. Pothal, please start sharing your slides. Now, everybody knows he's Dr. Sudarshan Pothal. He's been promoted as professor in Puri Medical College, and he is the real Sudarshan of Vimsar. He has been the MCI nodal officer for long and has been selflessly working. And now he is the main person who goes as per guidelines in the treatment of COVID-19 patients and does a lot of work. So over to you, Dr. Pothal.
Thank you, madam, for nice words. May I audible to everybody?
Yes, you're audible.
Okay. Right. Respected Chairperson Guno sir, my esteemed Dean Dora madam, my director Professor Lalit sir, and esteemed guests and speakers, panelists, and participants. First of all, it's my a great pleasure to use this platform to share my few of my experience during the COVID pandemic. During my discussion, it will continue hardly say 10 minutes. Within 10 minutes, I want to I want to try to my best to give the justice to the topic as well as justice to the time. As you know, in Vimsar, in fact, we have experienced around, say, by treating roughly around more than 7,000 hospitalized COVID patients, out of which, again, roughly around more than 2 times of indoor patients. That means roughly around more than 10,000 patients of OPD treatment. As you know, during the time of pandemic, since if you go through the any research engine, so for example, say PubMed, once you click the COVID management, you will find that more than 7,000 articles published in span of hardly 1.5 years. That's why it's based on the clinician. We have to understand which is the best tool to accept the research article. As far as my knowledge is concerned, as well as all over and trusted website and trusted site for follow the guideline and follow the advisory is NIH guideline by USA, National Institute of Health guideline. Based on that guideline, our also government of India also guideline or our ICMR guideline also formulated based on that NIH guideline. During my discussion, I will highlight these 4 to 5 parts, particularly the management parts, oxygen inhalation, anticoagulant, antiviral, anti-inflammatory, and some other drugs. Out of all therapy, if you realize since last 1 year, what is important to me here is to know the severity. Important thing here, everybody knows what we mean by mild, what we mean by moderate, what we mean by severe disease, based on the classification of clinical classification, based on the oxygen saturation by pulse oximetry. But change is here. Previously in the first wave, we are completely rely on microbiological assay. That means either in the form of a rapid antigen test or in form of RT-PCR or in form of TrueNet. But what the second wave taught us, about the use of radiology, means based on chest X-ray or HRCT. This severity, or what I mean to say, if you analyze this, the severe part, that means in severe COVID-19, we have to not only focus in microbiological finding, but also we have to rely in chest X-ray or CT scan. That means in chest X-ray finding, if a CT scan finding, if long infiltrates more than 50%, that means probably it is a sign of severe COVID. Why it is important? Because the mild case, we need patient need not to admit hospitalization. That means enough by home isolation and some drugs. But in moderate and severe cases, we need to hospitalization because these group of patients are usually progressive, and this group of patients needs constant monitoring. That's right. Second part, one important thing is whenever any symptoms arises, the most commonest symptom, as you know, cough, fever. But dyspnea usually arises 4 to 8 days after symptoms, whereas ARDS means acute respiratory distress syndrome, the progressive, roughly around median onset of 2.5 years after the 2.5 days after the onset of first symptoms. Out of all treatment part, here one of a hypothesis, of course, it's not a proven part, but it is a most more important. Why? Based on this, pathological basis, we can apply, which drug is better in which stage. If you analyze this graph, you can see that stage 1 is early infection, stage 2 is pulmonary phase, and stage 3 is hyperinflammatory phase. Why we need to know this? Because, say for example, viral response phase is roughly around stage 1. There is no, say, watertight compartment. However, this is a proposed algorithm where we have to rely on this because since last 1.5 years, based on this guideline and this pathogenesis or pathology, we are using our drugs. Why I mean to say, because the early stage is a viral response phase where antiviral may help, whereas in later stage is a hyperinflammatory stage where steroid or anti-inflammatory role is quite high. For example, where this part, the early part, there is very rare incidence of or a rare prevalence of inflammatory response. That's why we should avoid anti-inflammatory drug in early phase. Whereas in later phase, means stage 3, there is no role of antiviral because viral replication almost halted. Next, come to the about management part. Since last 1.5 years, what I feel, majority of patients, COVID patients, are emotionally imbalanced, very much panic stage. Not a single guideline is mentioned about how much verbal touch or healing touch should be given to the patient. In my experience, I have felt that majority of diet patients are very much apprehensive before the death. We, the healthcare professionals, needs counseling the patient, if either by verbal touch or by healing touch. That means based on some emotional talk with the patients, we can heal many important parts of the patient's emotion and patient's panic part. That is the most important part. Next part is about oxygen therapy. Yes, everybody know about oxygen therapy, but there are many methods of oxygen therapy. Delivery method like oxygen, that is nasal pronge or KS mask, or NRB and the non-breathable mask, or bench circuit, or HFNC, high flow nasal catheter, or ventilator. Out of all methods, why it is important? Because whenever we are giving oxygen, we should know important part is how much oxygen delivery rate, because oxygen is a drug. It should be given proper dose also. That's why, because it has also side effect. That's why suppose we want to give a patient nasal mask. That means ideal flow rate should be 6 to 15 liters. That means suppose we want to give a person having say oxygen flow rate 2 liters. So ideal method, delivery method should be nasal pronge. Not only like this, but also during the second wave, we have felt that there is many more the hue and cry about the oxygen shortage. Probably, if you judiciously use and judiciously plan how to utilize the oxygen in proper way, we can manage in better way. Second part is about the oxygen source. As you know, the oxygen cylinder, oxygen concentrator, the ESA, and the liquid oxygen system. Why it is important? Because if we are know the rate of utilization of oxygen per patient, then we can plan at the source of oxygen we can make to our hospital. The target of saturation, oxygen saturation for in general patient is 90 to 96%, whereas in chronic hypercarbic patient is roughly around 92%. That means whenever we are using the oxygen, it should be judiciously used and optimally used, because better we should avoid the side effect of oxygen also. But last, we should not forget about the airwalk pruning. Airwalk pruning is one of the important part of the oxygenation in adult patient, particularly during where there is indicated. If patient is hemodynamically stable, we can advise each and every patient, those having hypoxemia, particularly proning posture, because many studies show that proning posture is improved the oxygenation many times, even without oxygen requirement may be there. Next part is anticoagulant. Anticoagulant we are using many of times, but one of the recent and advanced based on the NIH guideline, it has been seen that most important part is antioxidants should be prescribed only hospitalized patients. And low molecular weight heparin is a better choice than the oral anticoagulant. But dose part is very much confusing. However, based on few advisory, either from ICMR advisory or from the NIH advisory, it should be given prophylactic dose in moderate and severe illness. Prophylactic dose of low molecular weight heparin is roughly around, say, based on the body weight. If patient's body weight is less than 70 kg, the ideal dose is around 4,000 international units subcutaneous once a day. If body weight is more than 70 kg, then 6,000 unit international unit for subcutaneous once a day. Second, sometimes higher than prophylactic dose may be required, particularly patient having critical illness. Say, for example, for low molecular heparin, we can use same dose, but in BD dose, means 4,000 to 6,000 international unit in the BD dose. The rest part about therapeutic dose. Therapeutic, particularly preferred therapeutic dose is again unfractionated heparin, that in IV form. Either it is indicated particularly deep vein thrombosis or venous thromboembolism or pulmonary embolism, so on. Next part about the important part is whether we should give anticoagulant during the time of discharge or not. Answer is no. It should not be given routinely. However, if patient having some other indication of comorbidity or risk factor of venous thromboembolism, in that case, we can give oral anticoagulant. Again, about the oral anticoagulant, prefer oral anticoagulant is about directly oral anticoagulant like apixaban or rivaroxaban. Then the duration of anticoagulant is during the hospitalization. Ideally, our average hospitalization for the patient is around 10 days. That's why duration of hospitalization means 10 days. So duration of anticoagulant is roughly around 10 days. Next thing arises in mind, whether based on which investigation we will rely monitoring the anticoagulant dose. Ideally, in mild case, not required, but in hospitalization case, hospitalized patients, they may require to some extent. For example, suppose a patient having moderate degree and going to a severe category, and some investigation like D-dimer is raised severely than the previous report, then only we can step up the treatment. This is one of the monitoring part. So there is a proposed algorithm of anticoagulant. Based on this algorithm, again, two score is Padua score and Caprini score, whatever may be. The Padua score and Caprini score are based on the clinical some risk factor of the disease, whereas ISTH GIG score is somehow about the investigation finding like a platelet count or fibrin or prothrombin or D-dimer, so and so. Just I want to highlight here the important part is in mild moderate case, based on our clinical history, we can modify the treatment. Whereas in severe case, based on some investigation finding like platelet count and D-dimer on a PT and prothrombin time, we can modify the dose of anticoagulant. Next, about antiviral. The only antiviral, remdesivir, which is approved by US FDA. rest of none of the any antiviral like favipiravir or any say antiretroviral therapy, whatever may be the previous were ritonavir and so, that are not approved. Only important antiviral which is approved by USA FDA is Remdesivir. That's why I want to highlight this only part, this antiviral only. This is indicated particularly hospitalized patient, those required oxygen. That means, suppose a minimal oxygen requirement that Remdesivir be used, or if a patient required more high flow oxygen or NIV, in that group of patients, in addition to antiviral Remdesivir, we can add steroid. But thing is that duration is hardly for 5 days, because based on the recent randomized control trial, duration of treatment 5 days, 5 days is equally effective. 5 days is equally effective than the 10. That's why duration of treatment is 5 days. But it should not be given particularly 3 group of patients: pregnancy, lactation, and having creatinine imbalance of CKD patient, and pediatric below the 12 years groups. Next part about the anti-inflammatory drug. The drug which has been tested by the mainly the recovery trial, the only based on that trial means the only anti-inflammatory drug which has been tested, like dexamethasone. We are extrapolating the same dose versus to other, and if dexamethasone is unavailable, not available, then other steroid may. But the tested drug is dexamethasone. Again, dexamethasone should be given hospitalized patient, those patients required oxygen. Dose is hardly 6 milligram per day. Then important about the duration of treatment. The duration of treatment is hardly 10 days. At times, frequently question arises after discharge whether we should advise the steroid or not. Ideal answer is not, because steroid worked in inflammatory phase. But after 2 weeks, patient already land in fibrotic stage. In that case, usually steroid usually not helpful. However, in some special cases, at times, suppose patient's CT severity score is very high. In that case, we may advise some steroid with constant monitoring to look out any side effect of steroid, because it is very, very much important. Many of patients were coming to the follow-up with high dose of oral steroid. That create again myopathy, which is again increase the breathlessness to the patient. That's why duration of steroid and indication of steroid, we have to very much cautious during the prescription. Next part about some of the, this is a recent article published where the role of inhaled budesonide. In this study, they have highlighted that the early administration of inhalation of budesonide, dose is around 800 microgram 2 times a day. This reduces the urgent medical care and the hospitalization. But preferably, this budesonide inhaler ideally should be given. Ideally should be given again the first week of the disease. That means if a patient's persistent fever and cough during the first 5 days, ideally we should be advised, because based on this study, it has been seen that this inhalation of budesonide in the dose of 800 microgram 2 times a day increase the or decrease the need of hospital care. This is one important part. Next part about frequently we are advising azithromycin in mild case. But based on this study, it has been proved that in mild to moderate COVID-19 management without hospital admission, adding azithromycin to standard care treatment did not reduce the risk of subsequent hospital admission or death. That's why, of course, very often we are using just because they're having anti-inflammatory property. But unfortunately, this study shows that by adding azithromycin does not gain any benefit to the patient. This is almost all to the end of my talk. But take-home message for this year: healthcare staff should provide best possible human touch towards the patient. It is very much vital, very, very much vital, because it works very nicely. Once we touch the patient, once we talk to the patient nicely, emotionally, we can take their emotional up. Second part, oxygen is a drug. It should be used in proper dose and through proper device, because as I told you, dose depends upon the which device you are using. If you are using nasal prawns, ideal dose is low. If you are using mask, then ideal dose should be high. Low molecular weight should be used in hospitalized, moderate and severe degree of patient, those who are required oxygen. Like that also, antiviral means remdesivir should be restricted to those group of patients, those are required oxygen. And dexamethasone should be used in patient, those required oxygen supplementation during the hospitalization. Thank you so much for a nice hearing, and thank you giving the opportunity. Thank you to the society giving me opportunity to share my view and thoughts in this platform. Thank you so much, sir.
Thank you, sir. Very nice presentation in a very compiled form. Please stop sharing your slides, sir. We'll have the question and answer session at the end of the talk. So,
yes.
So we are over to Dr. Bimal Ponda. He will be speaking on ventilatory management of COVID-19. I'll just full screen. Is it visible? Is it visible? Is the slide visible?
Yes, yes.
Okay, so Bimal Ponda sir, you can start. He is a professor in anesthesiology and he has a very strong background. He is MD from BHU and he has worked as SR at AIMS Delhi. Over to you, Bimal sir. You can start presenting your slides. Hello. Bimal sir. Hello. Just please bear with us. I'll just call him up.
Please unmute, sir.
Bimal sir, please unmute.
Hello, am I audible?
Yes, sir.
Actually, I was having some issue. That's why. At first, I would like to thank all the organizers, all the associations which are involved for making this a reality. And today I am presenting.
Next one.
I would like to thank all the participants, all the panelists, all the discussants and the speakers, and my respect to all the senior members, and my love to all my juniors. At first, I'd like to say that which kind of patients are posted for my ventilatory management. Usually, these patients who suffer from COVID-19, they usually have alveolar infiltrates in their radiograms, and the respiratory distress appears to be more in comparison to the vascular insult it has. And indeed, there is a wide variation of mortality in these kind of patients in the different ICUs. So, a possibility was raised whether the ventilatory management could contribute to any of the outcome. And which kind of patients are usually present in this scenario? They are patients who are having respiratory distress and respiratory rate predominantly more than 30, and who are having oxygen desaturation even with the saturation with supplemental oxygen, they have saturation of less than 90%, or with long infiltrates which are more than 50%, and with clinical deterioration of all the parameters which you have. So before going to the ventilatory strategy proper, we must at least know something about the pathology, little bit of pathology about what happens in this kind of are my slides visible? Slides?
Just a
No,
minute.
no, it's not. It's not.
No,
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 not
no,
visible.
not there.
Not visible.
Okay, madam, I am trying to share from here. Let's see the way it was told.
Sharing is also not there. Now it is come.
So it has come,
Yeah,
Screen sharing.
yeah, yeah, it's come.
No, you're
but it
sharing.
is not. It is not going. Not moving.
Slideshow
The only
Ah.
first slide.
mode.
It is not moving.
Actually,
I don't
I was doing it maybe because you also started doing it.
Oh, madam, kindly you do it. I am stopping my share,
Okay.
and you can that would be better. Madam, go to the lung pathology side. Okay.
I'm just
Because-
doing it. I'm just doing it.
Actually, I was not seeing that video. That is the reason why I thought I may be going fast or slow. So you have to complete within 10 minutes.
Okay.
Next slide.
I'll just go to the next slide.
So these are the ICU admissions criteria, which I hope everybody knows. And this is in gist of the lung pathology which we may get, because the inflammatory response, which has been nicely said by the earlier speaker, Professor Kothal, that due to the activation of the coagulation thrombin generation of the cascade of the coagulation cascade, what all those things happen. But usually there are two kind of phenotypes, L type or S type. But intermingle there might be a whole volley from L to H type, and they progress to a fibroproliferative variety. So in this, there is a possible explanation that such severe hypoxemic stress is occurring because there is a loss of lung perfusion regulation or hypoxic vasoconstriction. And there is next slide, madam. So the rate of this fraction is fraction of the gasless tissue. That is usually in the ARDS patient, which we get, is roughly around 1.25. But according to the Gattatoni et al. Did their finding in Italy in the earlier phase of the COVID-19, where they had many patients admitted into the ICU, they found that surprisingly this ratio was very more. I think roughly around 3 times. So there was a remarkable high perfusion to the gasless tissues. So this I hope will give a gist of what we find next in the patients. So the respiratory support follows after this only, and we give oxygen with low flow or high flow system, non-invasive fashion. Then gradually, if the patient doesn't respond, then we go up to the ECMO. This is a general scheme. Next slide. Then this is a general scheme that flow anesthesia. Then we give high flow anesthesia. Then we go for AVEC prone ventilation or invasive ventilation, prone ventilation or ECMO. Next. So how we manage hypoxic respiratory failure ARDS patient? We continue to oxygen by phase, which has been earlier told. So we have to see that the required maintenance to inflation of the back will be roughly around 10 to 15 liters. To from 0.6 to 9.5 or 1 is being there. Hypoxemic respiratory failure in ARDS commonly from intrapulmonary ventilation perfusion mismatch or shunt, which I had told you earlier. And the first mode which we are utilizing is HNFC or high flow nasal oxygen cannulation. When the respiratory stress or hypoxia of the patient cannot be elevated after relieving of stand oxygen therapy, we have the chances to go for the non-invasive ventilation or for the And the many studies shows that HNO4 has a better outcome than the non-invasive. And second, HNO4 is light as compared to invasive ventilation, and it is compliant to the patient. So what it does, it prevents dilution of the carbon dioxide accumulation and reduces the deaths. And next, and it causes elimination of the dead space. And there are some reports which says that it provides some amount of PEEP because the effect of PEEP has been seen with institution of HHC. So that is beneficial to the patients. And how we started? We start with a flow of 20 to 30 liters per minute with a FiO2 of 40%, and then gradually we increase it up to 60 liters. Some machines give 60, some machines give 50. So when patient has worsening of hypoxemia without significant work of breathing, or there is sign of impending failure, we have to prevent or avoid HNFs. For the patient is in shock, we have to avoid HNFs. And or the patients, when it is requires intubation, then we have to intubate the patient. HC is not a breeze in between. And next, when there is patient doesn't improve or they worsening, then we go to non-invasive ventilation. Next slide. And here CPAP is preferred by PAP. And when there is good lung comes, but severe hypoxia due to loss or aggression of blood flow, or self-induced lung injury is there, or malignant atelectasis. In these patients, we use, and next slide please, the setting, initial setting will be of pressure support of 5 to 15. So the adjusted volume can be from 5 to 7, and PEEP from 5 to 10 centimeter. With the FiO2, you titrate according to the patient's size, which should be maintained between above. So the goal will be to have a tidal volume of 6 ml for the ideal body weight of this. And when you should stop? When we try for 1 to 2 hours and we when see that the patient's oxygenation is not improved, or there is more of work of breathing at that time, or there is no remarkable improvement in the ABG, or there is more acidosis, that is time we should switch on to invasive mode of ventilation. And the crucial, next slide, the crucial is the decision when to intubate the patients. When there is rapid progress or hours, and the criteria to intubate, and it is not responding to the usual mode of non-invasive or HNFC, or there is more hypercapnia, there is decreased nation, or there is more hemodynamic instability, that is the time we should intubate. Next. So ideally the intubation should be performed by a very trained, experienced anesthetist, and practice should give 100% oxygen, because these patients of AIDS desaturate very quickly, and at that time some of the catastrophe may have occurred, and we should go for rapid sequence intubation in these kind of patients. What should be the next? What should be the ventilatory setting? We must go for a lung protect ventilation. Initially, we should start with a lower from then gradually we can extend up to 10 centimeter or even to 18. We should target for a low tidal volume, that is around 4 to 8 ml of it. And but the driving pressure should be always less than 15 centimeter, and the plateau pressure should be maintained around 30. So this is the lung protective ventilation. Next, and how we should graduate our PEEP and FiO2, because the oxygenation is very important, and we must know that we have to maintain a oxygen saturation of more than 90% in this case of patient, the 88 to 96. In this range we have to maintain, and for that we need to either go for a lower PEEP higher FiO2 strategy, or for a higher PEEP lower FiO2 strategy. That is according to the responsiveness, either it is L type or H type. When in L type, if you are giving PEEP, it will not be beneficial. neither the prone positioning. And these kind of patients, the Chang or Liu et al. In the Chinese, they tried with some rescue strategy, and that had helped. So not only the strategy will help, and when they fail, you have to go for deep sedation next. So you have to go for deep sedation or deep analgesia, because whenever you are intubating a patient and ventilating, patient feels pain, and if patient is awake, then counter-regulatory hormone will be secreted more, and that will be more detrimental to the patient, and it will affect the recovery. So adequate sedation is a must, and there are many drugs which most of the drugs are known to depress the cardiovascular system. But we have to give adequate sedation to the patient so that the patient is not aware of all these activities. And sometimes we next we have to go for deep neuromuscular. We have to go for neuromuscular blockage. Neuromuscular blockage either in decrease the patient ventilator dysynchrony, or you can decrease the respiratory muscle oxygen consumption. Thereby, you reduce the acidity. And sometimes sedation is also required along with paralysis, because if you paralyze without sedation, then the situation is very peculiar. And this has its innate effect, not that it is free of any effect. It will go for gradual muscle wasting later on, and it will be difficult in recovery. So next slide. Next slide. So this is prone position, because now there has been recommendation that because predominantly in the dependent side we are having atelectasis, and the aerated sites are situated in the anterior portion. So for better ventilation perfusion matching and for better secretion clearance, we need to maintain this with prone position. And now it is recommendation that from 12 to 16 hours they are trying to make prone position. This is how prone This is how prone positioning occurs. Next slide. So we suggest the positioning when there is failure of ventilation, because when oxygen ratio, PaO2 by FiO2 ratio, PF ratio is less than 150, and the oxygen FiO2 is more than 0.6. The requirement of PEEP is more than 5. At that time, these are the candidates to be made prone. And with prone, that too not 1 to 2 hours, it has to be 12 to 16 hours. The difficulty is this is you need next slide. You need experienced staff, and it is a labor intensive process, because you have to prepare. Then you have to act in a coordinated manner. Otherwise, the tubes, even the attachments, your pipes, lines, everything will detach out. So for prone ventilation, you have to prepare, you have to plan, then you have to perform, and then you protect, and you see that all the pressure points are taken care of. Next. So it is a very labor-intensive procedure requiring a coordinated effort, and minimum of 3 staffs are needed to do the log rolling. And the trauma care, they know how to log roll. So those criteria, or we have to act here also. And the head of the bed should be elevated to 30 to 45%, so that we don't have reagitation, and prevent some of the complication of next. So where next? So where this is contraindicated, soft patient, or patient is having electric bleeding, or there is spinal instability, obviously pregnancy, and there is antecedent complications also. Nerve compression may be, and there will be venous stasis, the endotracheal tube may be dislodged, there will be pressure, so there will be retinal damage. So all these things are there in prone position. Next. So, if the patients fail all this, we must have something. So, we go for different manner where we try to see that the collapsed alveoli are open so that the oxygenation is improved. If it also fails, we try for pulmonary vasodilators like ipoprostenol or nitric oxide. And neuromuscular blockade, continuous neuromuscular blockade with refractory hypoxemia, wherever is there. And as a last resort, we can go for bypass, that is ECMO. And along with this previous one, need not only the ventilatory strategy will occur, whenever the patient is put on ventilator, there will be so many complications occurring of it. One of the commonest known is back. So you have different bundles. So in the ICU setting, wherever such patients are there are some mnemonics like you have to see that there is feeding, analgesia is there, hand of the bag should be raised. So all this, you reduce the days of mechanical ventilation. You reduce the incidence of ventilator-associated pneumonia. Try to reduce venous thrombosis. Try to reduce the catheter-related bloodstream infection and incidence of breast ulcer. And instead of all ICU-related weaknesses, that is also there. And we have to prevent and manage the opportunistic infection like mucormycosis.
Sorry to interrupt.
So, these are few of the recommendations of the National Institute of Health. And the A stands, this is also, they have also used the grade system. Recommendation is A, B, C, strong, moderate, optional. And the evidences is 1, 2, and 3. 3 is expert opinion. And 1 is with a major randomized trial. So the panel recommends the endotracheal patients with COVID-19 be performed with a expert person, preferably through a video laryngoscopy. And if there is respiratory failure, the panel recommends high flow nasal over non-invasive positive pressure ventilation. The fast should be there. And in the absence of any indication for intubation, the panel recommends that you can use non-invasive X-ray if HNFC is not available. So the panel has recommended so many things, but the ventilator strategy which the panel has recommended is the panel recommends using low tidal volume ventilation from 4 to 8 ml of predicted body weight over higher PT. And this has the highest grade, that is A1. Means it has been tested by randomized controlled trial, and it has been found that this has the highest recommendation. And second recommendation goes to the targeting the platelet pressure. Platelet pressure should be made less than 30. And in these kind of patients, we can use conservative fluid strategy.
Sorry
But the panel recommends inhaled nitric oxide. So, in the early stage of COVID-19 in the L variety, if you start early, this is a deviation from what the current practice of COVID is going on. If you start early, you
Sir, let us finish it quickly, sir.
nitric oxide goes to the aerated lung, not to the non-aerated lung. So the aerated lung, because of nitric oxide, there is vascular flow and more of perfusion occurs. So the Chinese group, they found that there's better in oxygen in the early phase of patient put into it, not in the later stage. Next. So we have in a gist compiled everything. So the take-home message should be the initial approach should be with our oxygen. We should start the initial oxygen saturation to be around 92. And if there is hypoxemia, then we should go for HNFC or bypass, invasive, non-invasive. Then gradually, accordingly, we should go for investigation and we should take additional care to see that cardiac output is maintained. You have to give inotrope, analgesia, sedation, early nutrition. All these should be taken care of. Next. And rapid sequence, as already I have said, whenever a patient is in the ICU and with ARDS, there is every chance that the patient will desaturate very quickly. So it's for rapid sequence intubation. Next, and this is the seminal the guideline given by the ARDS network, and this is followed. The same we have to calculate the predicted body weight. Accordingly, we should initiate the tidal volume and progress gradually to see that plateau pressure is not over 30, and monitor ABG, and accordingly we should adjust the tidal volume. But last but not the least, the best way you can do while ventilating patient is to buy time, and thereby you can cause minimal damage by maintaining the lowest possible speed and gentle ventilation. Like patient, we need to be patient. Thank you. Okay, next slide. Thank you.
Hello, I think it's over. Hello, I hope I'm audible.
Yes, you are audible.
We'll go over to the next speaker. Let me say here, Babagrai sir, you will be the next speaker. Please share your slide. And let us please stick to the time and be very brief in our discussion.
Meeting.
Yes, sir. Babagrai sir, please share your slide.
Yes. Respected chairperson, Gunasagar sir, respected director, respected dean and principal,
Share your slide, sir.
IMA, Indian State Ophthalmology Society, other guests, and co-speakers. And at the outset, I also express my gratitude
Sir,
for
please
giving
share
me
your
this
slide,
opportunity.
sir.
And I am going to present this topic on updates on monoclonal antibodies in COVID-19 management. So monoclonal antibodies,
The slide not visible, sir.
they are lab-made protein
Sir,
that mimic the immune system's ability.
Babagrai slide dekha jauni.
slide share karantu, sir.
Slide share hi nahi.
Nahi, share karo.
I think I shared my slides. No.
It's not visible, sir.
My slides are not visible.
No.
No, sir.
Hello.
No, sir, you have not shared.
Hello.
Yes, sir. It's not visible, sir. You have not shared.
Okay.
Please mute yourselves, all of you. Last time it was a huge noisy thing.
Is it visible now?
No, sir.
It was visible initially. What happened now?
That
Okay,
was
so sorry.
a trial session, sir. Now you have to share it again. Hello.
Hello.
Yes, sir. Please share, sir.
ଆପଣ ପାଖରେ ଆସିଲେ ପ୍ରୋଜେକ୍ଟ କରି ଦଉନାହାନ୍ତି ସେୟାର କରନ୍ତୁ ବେଟର ହବ
ମୋ ପାଖରେ ସେଟା ନାହିଁ ସାର୍ ମତେ ମେଲ କଲେ ନହେଲେ
Not visible.
No, sir. Same here screen रे तले थिबो sir share
ହଁ
screen
ସ୍କ୍ରିନ୍ ରେ ମୁଁ ସେଟା ତଳେ ତ ମାରୁଛି ସେଟା ଇଏ ହଉଛି
share screen କରନ୍ତୁ sir.
स्लाइड शो मोर करके करूँ
ସେୟାର ସ୍କ୍ରିନ୍ ବଟନ ତ ମାରିଲି ସେଟା ତ ଆସୁଥିଲା ସେୟାର has failed to start.
ଆପଣ ଡେସ୍କଟପ୍ ରେ ଟିକେ ଖୋଲି ଦିଅନ୍ତୁ, ସେଟା ରଖନ୍ତୁ, ଡେସ୍କଟପ୍ ରେ ଖୋଲି ରଖନ୍ତୁ, ତାପରେ ଆପଣ ସେୟାର କଲେ ସେଟା ଆସିବ। ଫାଷ୍ଟ ଓପନ ଇନ୍ ଦ ଡେସ୍କଟପ୍, ପ୍ରେଜେଣ୍ଟେସନ ଟା ଖୋଲି ଦିଅନ୍ତୁ ଡେସ୍କଟପ୍ ରେ, ଦେନ୍ ସେୟାର ସ୍କ୍ରିନ୍ ସେ ଖୋଲି ଦେଖେଇବ, then you can share it। ଆଗ ଖୋଲି ଦିଅନ୍ତୁ, ସେ ପ୍ରେଜେଣ୍ଟେସନ ଟା ଖୋଲନ୍ତୁ ଆଗ ଡେସ୍କଟପ୍ ରେ। now it has come।
Yes sir, now we can see this।
no it's not, it's coming, check କରନ୍ତୁ, it is not come now।
Hello, nothing audible.
Yet to come, it is not come yet। now I can see, so that yes, right, now it has come।
Yes,
It is visible now.
yes visible।
yes sir.
So updates on monoclonal antibodies in COVID-19 management. So monoclonal antibodies as they're effective in COVID-19, I would classify them into two categories. One is by virtue of their antiviral action, and another is their monoclonal antibodies that are only used for their anti-inflammatory properties. The first groups of the drugs, they're casirivimab plus imdevimab. They're popularly known as antibody cocktail. There is another antibody cocktail also, that is bamlanivimab and plus etesevimab. There is another one, that is sotrovimab. So these are the three anti-SARS-CoV-2 monoclonal antibodies. They are antiviral. There are other three, tocilizumab, itolizumab, and sarilumab. They are actually monoclonal antibodies, and they are anti-inflammatory monoclonal antibodies that do not have specific antiviral effects. So as we know, SARS-CoV-2 genome encodes for 4 major structural protein envelope, nucleic acid, as well as non-accessory proteins. And the spike protein has got 2 segments of units, S1 and S2, and this mediates host cell attachment and invasion. S1 attaches to SE2 receptor on host cells, which leads to a conformational change in S2, and that leads to viral host cell fusion and viral entry. So monoclonal antibodies, when they target the S protein, they prevent the viral host cell fusion. Therefore, the infection is prevented, symptoms are alleviated, and progression is limited, that severe disease is limited. Casirivimab 1200 milligram plus imdevimab 1200 milligram, either subcutaneously or intravenously they are given, then and they target the non-overlapping epitope of receptor binding domain of S1 subunit of spike protein. Bamlanivimab 700 milligram plus etesevimab 1400 milligram, they attack the spike protein of the virus. Then sotrovimab, it also attacks the spike protein of the virus. And these anti-SARS-CoV-2 monoclonal antibodies, they are only given in mild to moderate COVID-19 in non-hospitalized patients, and those patients who are having high risk of progression to severe COVID. They are never recommended for inpatients or on ventilation, or who are on chronic oxygen therapy. In these conditions, if they are used, it might the condition might worsen. And as soon as a positive diagnosis is made, or even maximum within 10 days of symptoms, these drugs can be given if indicated. There are other conditions are also there. And main condition is the high risk of disease progression. If a patient is coming with mild to moderate COVID-19, and one cannot use these drugs unless there is a high risk criteria, because these drugs are not approved. They are only approved for emergency use authorization, and there is a long list of who are the patients there to in which these monoclonal antibodies are indicated, like body mass index more than 35, chronic kidney disease, diabetes mellitus, both type 1 and type 2, immunocompromising condition, who are on currently immunosuppressive therapy, and when age is more than 65 years, And when it is more than or equal to 55 years, those who have cardiovascular disease, or hypertension, or COPD, or other chronic respiratory disease. When the age is 12 to 17 years, if the BMI of more than or equal to 85th percentile for their age or gender, or sickle cell disease, congenital or acquired heart disease, or neurodevelopmental disorders, a medical related technological dependence that is not related to COVID-19, like tracheostomy, gastrostomy, positive presentation, or asthma, or similar respiratory disease requiring daily medication. So these groups of patients, if they are having mild to moderate COVID-19, only in these patients monoclonal antibodies are indicated. It's the antiviral monoclonal antibodies. I am not talking about the anti-inflammatory monoclonal antibodies. Then casirivimab, imdevimab, these are known as antibody cocktail, IgG1 against SARS-CoV-2 virus. Why these two are combined? If you are using only one, then there will be mutational escape. That is the reason why both have to be combined, and either these are given IV infusion or subcutaneous dose, and then based on multicentric trial, that is the famous trial is there, that it has shown 81% reduction in hospitalization endpoint, and within 10 days of symptom, or as soon as the patient is detected positive, these drugs are used. Sotrovimab, it is approved as late as May 26, 2021 under emergency use authorization. It is given in a single dose. So sotrovimab is the only monoclonal antibody, antiviral monoclonal antibody, not used as a cocktail, a single monoclonal agent. So 500 milligrams single dose, single IV dose, and again the indications are always same. And it has shown 85% reduction in hospitalization or endpoint. And if at all it is given in hospitalized or severe COVID-19, the condition is going to worsen. These are about the anti-SARS-CoV-2 monoclonal antibodies. Then the anti-inflammatory monoclonal antibody, the most famous one is tocilizumab. It is a recombinant humanized monoclonal antibody. It blocks binding of interleukin-6 to both membrane-bound and soluble IL-6 receptor. This targets immune system hyper activity associated with severe COVID-19, and also it targets the mortality also. It must be used in combination with dexamethasone. It should never be used alone. That is the recommendation. Dexamethasone 6 milligram daily for up to 10 days, or equivalent corticosteroid has to be given. And in certain groups of hospitalized patients exhibiting rapid respiratory decompensation due to COVID-19, the trials what are they have been undertaken, they're unable yet to categorically streamline which groups of patients are really benefiting from this. However, some preliminary data are coming, and when used in hospitalized patients with COVID-19 pneumonia who are not on mechanical ventilation, tocilizumab has reduced the likelihood of progression to composite outcome of mechanical ventilation. And the dose is 8 milligram per kg, single IV dose up to maximum of 800 milligram. There are contraindications to this. There, if a patient is having significant immunosuppression, high alanine transferase, then high risk of GI perforation, uncontrolled serious bacterial, fungal, or non-SARS-CoV-2 viral infection. If the absolute neutrophil count is less than 500 cells per milliliter, if the platelet count is less than 50,000 cells per milliliter, there is risk there is a risk of severe and disseminated strongyloidosis that has come up, and therefore a prophylactic ivermectin is also recommended when we are going for tocilizumab therapy. There are several trials are there. One is REMAP-CAP trial. It has clearly shown survival benefit. The recovery trial it has also shown mortality benefit. COVACTA trial has shown that treatment lowered the incidence or duration of ICU and hospital stay. IMPACTA trial has shown the treatment lowered the composite rate of mechanical ventilation or death. And benefit is unclear for patients who received invasive mechanical ventilation more than 24 hours after ICU admission, because most of the trials there within 24 hours of ICU tocilizumab has been given. More than 24 hours, benefit is unclear. And if the patients are receiving conventional oxygen therapy, tocilizumab has not shown any benefit. However, there is definitive evidence to add tocilizumab for severely ill patients with COVID-19. There is another anti-inflammatory monoclonal antibody, itolizumab. It is again a repurposed drug. It was originally used for plaque psoriasis. It is anti-CD6 IgG1 antibody that blocks activation of T lymphocytes. It suppresses pro-inflammatory cytokines reduces mortality in moderate to severe ARDS. Dose is 1.6 milligram per kg every 2 weeks or 0.8 milligram per kg weekly for 4 weeks. Then the last one is sarilumab. It is anti-interleukin-6 drop to prevent fatal consequences of acute respiratory and multi-organ failure in around 20% of patients. And it is indicated in severe interstitial pneumonia with hyperinflammation. And when it is combined with combined with corticosteroids, treatment outcomes have been better. However, in contrast to tocilizumab, itolizumab and sarilumab, very less studies have been conducted, and we have gathered a lot of evidence for tocilizumab. We conclude monoclonal antibodies show promise in curtailing endpoint in this group. However, there is uncertainty as regards the extent of benefit and safety, as well as the patient subgroup likely to benefit. And the antiviral monoclonal antibodies, I want to emphasize, like the antibody cocktail, sotrovimab, they are not indicated in severe disease requiring oxygen therapy. In these conditions, if they are used, the clinical outcome is going to be worse. They are only used for mild to moderate COVID-19, and where there are specific indications as for emergency use authorization. And when we are talking about these anti-SARS-CoV-2 monoclonal antibodies, yes, emergence of mutational resistance is already a concern, and continuous monitoring is on. Evidence collection process is ongoing and would take more time to reveal the exact benefit of these monoclonal antibodies, whether they're antiviral or they're anti-inflammatory. However, as of now, we know that monoclonal antibodies do have an established place in the current management of COVID-19 across the disease spectrum. Thank you very much for giving me patient hearing. Thank you all.
Thank you, sir, for the brisk presentation. Please stop sharing your slides, sir. So the next speaker is Professor Dr. Prakash Panda. Panda, sir, please share your slide. He will be speaking on MISC. Prakash Panda, sir. Yes, sir.
Namaskar, everybody. Honorable Director, sir. Honorable Madam, am I audible?
Yes, sir. Very nice.
Yes.
Honorable Director, sir. Honorable Dean, Madam, and the chairperson of the event, Professor Gunasagar Das, sir. Leaders and members of Ophthalmologic Society of Odisha, IMA, Bulla, Sambalpur, and the prestigious UMTA, and all other participants and delegates available over here online. It is a proud privilege to share the problem of our little kids in the August platform. This is a photograph of a patient at present in our ward, bed number 16, named Mantu, age 4 years, from Kuchinda, Sambalpur, and the presentation is a viral fever for 6 stage with loose stool, pain abdomen, red eyes. There is a good tenderness of the abdomen with little bit of guarding, no pre-clinically, cardiovascular system reveals no abnormality, and respiratory wise the patient is normal. We evaluated with routine screening, everything was normal. The high point was that the CRP was 120. Platelet was a little low, albumin was a little low, ultrasound revealed mesenteric adenopathy, and acute abdomen surgical conditions are ruled out, and still we thought that we were missing something. Another girl aged around 12 years, also available at present in our ward, bed number 18, named Sumi, hails from Nuapada district. Here the screenshot is reflecting some these pathological investigations and other investigations. Fever for 5 days, ultrasensorium, 1 bout of seizure, some pallor, tachypnea, and there was a dangerous hypotensive shock. We thought it is a classical and this acute encephalopathy syndrome, and the differential diagnosis of this dengue, scrub, etc., and even severe malaria were rolled in. but the report did not support any of these things. And the high points in the investigational protocol found where CRP was around 200, platelets 55,000, hemoglobin little low, not so low as happens in malaria, liver enzymes little bit raised, when ferritin is 1,000, D-dimer is around 20, and malaria negative, scrub negative, and this is the dengue negative. So again, we thought that we are missing something. And all these leads little bit probing why we are receiving these sorts of cases nowadays. And that's why we are here to discuss about newer details about the newer problems. This is a small little chart which shows that the children are not more affected in second wave than in first wave. That is the apprehension in everybody's mind, and they are also now in apprehensive mood that the third wave is going to further consume more number of children. And the graph clearly depicts that in wave 1 and wave 2, the proportion were the same across all age groups, even if the numbers swelled up in terms of 4 to 5 times because of rapidity of the surge or the height of the peak. So we hope so. In third wave also, the proportion will remain constant and the wave height will remain little bit lower as compared to the second, and more so as compared to the first wave also. And this is the another epidemiological evidence. The sero survey conducted by AIMS over 5 states conclusively reported that the seropositivity in adults is around 50%, and seropositivity in the less than 80 years is also 50%. That means half of the adults in India are also having seropositivity, and half of kids are also having seropositivity. That means kids are in no way less affected by COVID. They are less suffering, less diagnosed, and less hospitalized. But the infection rate is almost same as that of adults. So in a nutshell, we can discuss COVID problem in children under 3 heads. Acute COVID, the second problem is MIS-C, and the third problem is a long-term outcome that is called long COVID. We know something about acute COVID, everybody. They suffer less. Mild attack is the most in 90% of instances. Almost 4-5% get into the hospital, and 1% case land in the ICU. The overall outcome is very good. And now, today we are here to discuss something about MIS-C. It is a very big chapter, little bit of comprehensive discussion is required, but time permits to go to A, to B, to C again. We will be brief in discussion. And this is the first time when a new cluster of children were found to having a common sort of symptomatology and signs. They were named as a new disease appearing in the horizon. On April 7th, it was detected in USA, 1 little infant. But in Europe, they got a cluster and tried to find out what is happening over there. That is the Europe. Then it spread in other parts, and then officially the different associations conglomerated and elaborated and discussed, and WHO declared that a new thing has appeared. And this is a syndrome because the spectrum of symptoms, signs, and some common defining characteristics are involved. And the gap is it is epidemiological curve. The little bit yellowish curve indicates the load of COVID waves or cases, weekly cases in the area, and the small little histogram bars, they indicate the cases or surge in the MIS-C cases. So classically, it depicts that there is a gap of around 4 weeks or 4 to 6 weeks between a COVID case surge or a MIS-C case surge. So this is the correlation temporally or time-related correlation. And the definition, WHO coined the term MIS-C, multi-system inflammatory syndrome in children. And the UK, their Royal College of Pediatrics and Child Health, they also came with a separate definition, but it's similarity is there in many points. It's called PIMTS, or Pediatric Inflammatory Multisystem Syndrome, temporally associated with SARS-CoV-2. There are other some call names, but these two are most accepted, and we in India follow the WHO definition. How WHO defines MIS-C? It's because it is a conglomeration of things. Underdiagnosis is a possibility, overdiagnosis is a possibility, and it's because it is a very new thing. Enthusiasts will diagnose many cases where they are really not the case, and the generalist will miss many cases. So age group, the fever, 2 organ system involvement, range inflammatory markers, possible link to a COVID-19 in the past, and ruling out of our available common differential diagnosis. These are the 6 components in the diagnosis. We will cover one by one. First, it is called MIS-C in children, but the age group is not only children and adolescents. And the common age group is 5+. School age is the mostly affected. Under 5, we don't expect much cases. So males little bit higher than female, but comparable. And the median age reported is 6.3 years. It is called Miss C, and now they are coming across another group affected in the adults also. Up to 30 years, it is being detected. They are calling it Miss A, MIS-A, adult. Epidemiology. Exact COVID cases in children we hardly count because we don't report. We don't screen all children. Whenever there is home contact or home exposure, we also screen the kids in the home. So we are missing many cases in the children. Sero survey can be a repetitive sample. All cases of Miss C are not tracked. Hence, prevalence very difficult to protect. It is uncommon. Incidence is around 1 in 100 COVID cases. Around 1% incidence. 2 per lakh population. Older children and adolescents more than 5 usual. No comorbid condition. The common thing is that serious COVID affects comorbid ill babies, but Miss C affects non-comorbid babies and healthy, robust children. So healthy children, Miss C. Disease children, acute serious COVID. And mortality also very low, 0.1 to 0.2%. And the number one component in the diagnosis is fever. We declare or suspect whenever a child presents with a fever without focus of more than 3 day duration, at least 100.4 degree Fahrenheit. And this is very common in our setup because of plenty of viral infection nowadays, the moment the COVID relaxation have set in. Second, we expect any 2 system involvement: heart, GI tract, skin, hematology, coagulation, kidney, nervous system. And in most of the cases, we are expecting 3 or 4 system involvement. And the more the systems, more the severity. Next, high inflammatory markers. The leader in the group is CRP. In many other common conditions, we expect a CRP level of around 5, 10, 20, 30, up to 40, 50. But here we are seeing it is in 100 plus. So very, very high CRP is a high pointer that it may be a case of Miss C. Common, another common investigation like ESR is also available. Fibrinogen may be high, procalcitonin, ferritin, D-dimer, etc. are also found to be high in many of the instances. Another component in the diagnosis is COVID-19 link. The disease condition must be linked to a past COVID-19. So it may be proved by serology, red positivity, RT-PCR positivity, history of COVID illness with the kit, or history of contact with the COVID case. So in most of these setups, we hardly get a COVID antibody screening, as because everybody is exposed to COVID. So whenever the clinical condition fits and the investigation on inflammatory markers fits, even if there is no direct evidence of the seropositivity, in view of epidemiological link, we declare the disease case of C. And classically, this is the literary descriptions. 2/3, almost 70-80% cases, we expect antibody positivity, IgG or IgM. But 1/3 case may be RT-PCR or antibody positivity. And in 1/3 cases, we hardly, very difficult to prove whether it is a COVID testing positivity there or not. Immunopathogenesis. What is the problem here? Why children get Miss C? The exact pathophysiology or pathogenesis is not there. But number one component is genetic predisposition. Number two component is it is a cytokine storm. It happens acutely in adults, blending in severity and mortality. It happens in a delayed, milder form in children. That's the difference. Delayed, milder cytokine storm. So stronger innate immunity in the children. There is a low interferon response in the child. So the virological clearance is a little bit slow. And it's because the antibody response, T cell response is not so robust in children. It comes a little late. That's why the manifestation is a little late. We know that hepatitis A, chickenpox, they are milder in children than in adults. Similarly, COVID is milder in children than in adults. This is called stronger innate immunity. Antigenic mimicry. We know there is a antigenic mimicry example like streptococcus and acute rheumatic fever. The same thing may be happening here. There is a thing that antibody enhanced immune inflammation is there. And the classical example is dengue. You get an attack of dengue, the first attack is milder. You get a second attack of dengue, it becomes more severe because of pre-existing antibody from the past attack. And another theory is the super antigen theory. They are all propositions. Here there is the delayed interfering response in children. And here there are two, we are screening for antibody, but antibody are two in variety. One is neutralizing antibody, which is protective. Second is non-neutralizing antibody, which is non-protective, or maybe playing some damaging role in this Miss C phenomena. So whenever we are screening for antibody, we are mixing the two and getting a total of the amount. Next, the dermatological picture, we expect skin rash, we expect desquamation, we expect maculopapular rash, we expect red conjunctivitis and non-purulent conjunctivitis. We expect cervical adenopathy, which is usually unilateral, not bilateral. We expect cracked red leaves. We expect a red tongue called strawberry tongue. And we expect edema of the hands and legs. So these are the classical dermatological presentation. Next common presentation is gastro, vomiting, diarrhea. These are common things. But the focus is acute pain abdomen, not mild pain, very severe pain. Even there will be guarding tenderness is there. We are tempted to put the baby to a surgical screening. Appendicular lump is may be found occasionally. Epididymoorchitis, ileocycolitis, serositis, intersusception is a presentation in most of the children. Pancreatitis is also a rare presentation. And hepatitis is possible. Hepatic enzyme is little bit raised. Low serum albumin, high triglycerides, hepatomegaly, occasional splenomegaly may be possibility. Then this is the cornerstone or the most serious form is cardiac involvement. 50% the present is cardiogenic shock. 90% present with left ventricular dysfunction, 10% arrhythmia, 20% with by mitral valvular regurgitation. The markers are cardiological involvement like TROP-T, CPKMB, and anti-pro-BNP may be positive. Even the marker is positive, clinically no cardiac involvement, you declare it is a cardiac system involvement. And ECG 10% may be screening arrhythmia. And these are the echo findings. Every case of MIS-C must be subjected to echo, even if there is no cardiological clinical presentation. Not once, but again during follow-up. The differential LV function, coronary abnormality like dilatation, aneurysm, mitral regurgitation, and pericardial effusion are the common things. And out of all, everything recovers. Only we are worried about the coronary involvement or the long-term coronary problem. Then hematological derangement. This is bread and butter for the clinician, and who can get some picture that there is some abnormality like lymphopenia, the neutrophilia, anemia, not severe, mild, moderate. Platelet count is definitely less than 1.5 lakhs. Then there is low serum sodium is the key point, and low serum albumin another helpful tool. Then renal, rarely involved, less commonly, it is a consequence of a shock, AKI, or maybe there is hyponatremia. Coagulopathy, another system involvement, thrombocytopenia, D-dimer, very high, INR, fibrinogen, PT, etc. Respiratory, rare. In acute COVID, lungs are the favorite hunting ground for the virus. In MIS-C, lung is usually spared. And whenever there is a respiratory feature, it is not due to primary lung involvement, it is due to pulmonary features out of a cardiac problem or some other problem. So lung is the only organ which is spared in MIS-C. And differential diagnosis, don't forget scrub, dengue, malaria, etc., vasculitis, toxic shock syndrome. In our setup, before you land that this is a case of MIS-C. Treatment, how to treat? The supportive care is must. Antibiotics to cover septic shocks, to cover scrub, etc. Supplemental oxygen, fluid bolus, vasopressors, blood products, GI prophylaxis, and ventilation rarely required. The drug of choice is methylprednisolone. Drug of choice in COVID, moderate to severe is dexamethasone. Drug of choice in MIS-C is methylprednisolone. 1 to 2 milligram is the low dose. In occasional cases, severe cases, these cardiac involvement cases, the dose may be increased to 10 to 30 milligram per kg per day. We go for 3-4 days, screen for the markers, screen for the clinical condition. The moment the baby is improving, prop and switch over to oral prednisolone. Total duration of treatment may be 1 to 2 to 3 weeks. Give over 1 to 2 weeks, the normalization of the markers, then taper it out over the next week. Another bread and butter is IVIG or intravenous immunoglobulin. In Kawasaki disease, we use IVIG, and in Guillain-Barré syndrome, we use IVIG. So this is another tool. Most of the guidelines they prescribe for IVIG or methylprednisolone, but IVIG availability is a problem here. So our drug of choice is methylprednisolone. Whenever it condition or situation warrants, you add on IVIG, or in a better situation, you may be starting with IVIG and then switching over to methylprednisolone depending on the organ system. So occasionally combination is the theory, and if there is relapse or refractory status, then also you can go for both things. Then whenever you are thinking to discharge the patient, go for aspirin. This is an antiplatelet drug, not anti-inflammatory dose. So low dose aspirin, 3 to 5 milligram per kg per day, may be continued to prevent long-term coronary artery changes. So this is prescribed around 4 to 6 weeks after the discharge, and echo, serial echo will say when to stop it. Contraindication is low platelet count. Anticoagulants, already Dr. Pothal touched it a little bit. Whenever there is a threat or active thrombosis, go for anticoagulation. Biologicals, hardly useful here, anakinra, infliximab, and tocilizumab. When to discharge, stable clinical status, stable cardiac function without vasopressors, no fever, downtrending markers. So repeat it twice. If it has fallen, switch over to oral steroid, go discharge the oral steroid and aspirin. So that's the motto. Follow up 1 to 2 weeks, call the baby. 4 to 6 weeks, call the baby. 3 months, 6 months, 1 year. And the focus is clinical markers, ECG, echo, and long-term cardiac CT and MRI. Cardiac CT to screen on the peripheral coronary vessels, and cardiac MRI to look for myocardial scarring. So short-term prognosis is very good. Shock treatment is critical, and ECG also improvement is very good. But the moment you are missing steroid, delaying the treatment, there are chances of high mortality. But it is treated cases mortality around 0.2%. Untreated, we cannot comment. Long-term sequelae, myocardial scarring is number 1. Coronary abnormality number 2. Serial cardiac surveillance is the call of the day, and cardiac screening by investigation is the demand of the case. Our experience, last year we encountered about 42 cases. This year, during the last 2 months, we have already added 20 more to the pool. So this is our case pool. We have already been included in a multicentric trial involving already Institute of Bhubaneswar. They are including all medical colleges. Even the government of India has started a reporting system to get a catch hold of the all India situation of MIS-C. The summary, MIS-C is an uncommon but often serious complication of COVID in children. High degree of clinical suspicion is the key. Underdiagnosis and overdiagnosis both are challenges. Unexplained fever with RAS and GI features with a very high CRP is a common presentation. Supportive care as HDO or ICU saves lives. Immunomodulation with methylprednisolone and or IVIG is the treatment of choice. Aspirin prophylaxis is a must in every discharged patient. Long-term follow-up is warranted to foresee and prevent cardiac sequelae. The case load of Wave 2 is a challenge in the next 2 months. Much remains to be seen on this emerging disorder. And to conclude, we can say, एक टाइम राजा था कोविड, अभी साइटोकाइन स्टॉर्म का जमाना है, राजा है MIS-C. Next time we hope vaccine will rule the state and it will be the king. Thank you very much.
Thank you, sir. We'll go over to the next speaker, Professor Dr. Malti Murmu. Please start sharing your slide. Malti ma'am, please share your slide.
Okay.
Please stick to time. I would request you to stick to time.
Okay. Okay, ma'am. I'll try my best to stick to time.
Prolonged.
Okay. Am I audible?
Yes, ma'am.
Respected chairperson, sir, respected director, sir, principal, ma'am, Anita, ma'am, all esteemed panelists, all discussant, moderator, all speakers of this evening.
Full screen kari diyantu, ma'am. Full screen.
Full screen. And participant of this evening. Today I will be talking about long COVID symptoms and management. So next 10 minutes, I will try to complete all my content and let us see. As we all know, COVID infection has created a global healthcare crisis. And according to WHO, SARS-CoV-19 infection gives rise to 20 to 30% hospitalization and 5 to 10% patient need ICU management, and death occurs around 6 to 9% of patients. And long COVID persist up to 2.5 to 15% of cases. And long COVID has been seen 4 times more following second wave in India in comparative to first wave. In absence of universal acceptance of definition, for this time being, working definition is like signs and symptoms that develop during the infection, following an infection consistent with COVID-19, which continue for more than 12 weeks and are not explained by alternative diagnosis. This graph showing the duration of COVID illness up to 4 weeks, acute phase, subacute phase up to 4 to 12 weeks, and beyond 12 weeks is long COVID. These are the terminology interchangeably used for long COVID. These are risk factors like old age, obesity, patient having asthma, multiple symptoms at presentation, severe symptoms at presentation, patient of Black, Asian, and minority ethnic groups are more susceptible. Females suffer 2 times more common than male, and comorbidities like diabetes mellitus, hypertension, coronary artery disease, heart failure, renal failure, organ transplant, and malignancy individual are at risk. Exact pathophysiology is not known, could be due to direct viral injury and persistent viremia along with systemic inflammatory response. And these are the other contributory factors to pathogenesis. Next is symptoms. More than 200 symptoms have been described in long COVID, and almost all systems are affected. So most common symptoms is post-COVID fatigue with or without exertion, that is seen in 93% of cases, persistent fever in 38%, and other like myalgia, arthralgia, body aches can also be seen. Weight loss and malnutrition is commonly seen in elderly individuals. And in respiratory system, shortness of breath is seen around 81% of cases, chronic cough in 63% of cases, and pulmonary fibrosis and bronchiectasis do present in small number of patients. Coming to the nervous system, headache is prominent symptom around 55%. Others like stroke, Guillain-Barré, encephalitis, seizure disorder are also seen, and other are rare like post-reversible encephalopathy syndrome, acute disseminated myelitis, cranial neuropathies. And in cardiovascular system, chest pain is more likely seen in 60%, and it can be due to respiratory origin, it can be due to musculoskeletal origin, and it can be due to cardiovascular origin. Palpitation arrhythmia is seen in 42% of cases. Postural orthostatic tachycardia syndrome in 25% of patients. Ischemic heart disease including acute coronary syndrome and pulmonary thromboembolism is also commonly seen in long COVID. Indigestion is a common presentation in GI system. Others like nausea, vomiting, decreased appetite can also be present in GI system. Thromboembolic is seen in less than 5% of cases due to hypercoagulability and microthrombosis. Residual renal dysfunction has been observed in case of follow-up case of acute renal failure during COVID infection. New onset type 2 diabetes mellitus, worsening diabetes mellitus is seen in 20% of cases. Subacute thyroiditis can present like Hashimoto's thyroiditis and Graves' disease. Anxiety, depression, sleep disturbances are common symptoms in psychiatric department. Others are post-traumatic stress disorder, hallucination, delirium can also be seen. Rhino-orbitocerebral mucormycosis is the secondary fungal infection very commonly seen following second wave of COVID-19 in India. And in our institute, mucor team has been treating this case, and till now 32 number of cases has been treated within last 2 months. These are the skin dermatological presentation. Hair loss is prominent symptoms, and others like COVID, morbilliform rash, macular erythema can also be seen. Anosmia is very common presentation. It can be seen in 55% of cases, and these symptoms extend up to 6 months. And other findings like iagisia, vertigo, tinnitus, blurring of vision can also be seen. These are the symptoms in reproductive system like erectile dysfunction and menstrual cycle disturbances. This topic has been taught just now by Prakash Panda sir. The diagnosis depends on history, clinical findings, and relevant investigation to differentiate between other differential diagnoses. As we see, long COVID-19 used to overlap with other comorbid conditions, hospitalization complication, and post-intensive care syndrome. Coming to the management, long COVID is a clinical challenge. Assurance to the patient and his family is crucial. The goal of treatment should be identification of the underlying problems, control of symptoms, and slow improvement of their ability to function. This management protocol is universal, and it is followed throughout the world, and all the symptoms of long COVID can be treated in this heading only. So it has got 5 parts: self-management, medical management, mental health management, safety netting and referral, pulmonary rehabilitation management. Under self-management, patients should check daily with pulse oximeter, oxygen saturation, attention to the general health care, adequate sleep and healthy diet, quitting smoking, limiting alcohol, limiting caffeine is important. Adequate rest and relaxation is very important. Self-pacing and gradual increase in exercise if tolerated. There should be setting of achievable target. Under medical management, treating physician should be listening to the patient very carefully and attentively and should have empathy to the patient. Symptomatic management, control of comorbid condition, complication management, and secondary infection management is under medical management. And patient should seek medical advice if worsening breathlessness, oxygen saturation less than 96%, unexplained chest pain, new confusion, focal weakness, and patient should be referred to specialist if indicated. And in case of prolonged breathlessness condition, pulmonary rehabilitation is very important. Coming to the breathlessness management, steady breath in through nose and relaxed out breath through mouth is very important. Ask the patient to sit comfortably, relax shoulder and neck, and these are the various positions to decrease the work of breathing and to reduce the work of breathing. For sleep breathing is breathe in through nose and breathe out through pursed lip. For focusing, extending the out breath. Rectangular breathing pattern is focusing to extending the out breath, and breath out duration is longer than breath in. Fatigue should be managed with adequate rest, gradual increase in activity, good nutrition, including balanced diet with adequate micronutrient supplementation, and pacing should be done. Slow down, break touchdown, regular short breaks should be advisable. Persistent cough management, one should take adequate fluid and inhale steam inhalation along with deep breathing exercises, cough suppression and antibiotic if necessary. Coming to the thromboembolic management, risk assessment prior to the thromboembolic management is necessary. If high risk group, it can be treated up to 6 weeks for discharge with enoxaparin, rivaroxaban, and dabigatran. Coming to the pulmonary fibrosis, pulmonary rehabilitation is the important treatment for fibrosis disease. Antifibrotic agents like pirfenidone and nintedanib are in use now, but outcome is doubtful. Coming to the cardiovascular system, according to the spectrums of coronary artery disease, it can be managed. Low dose beta blocker in case of arrhythmia induced by POTS. Cardiomyopathy and heart failure can be managed with limiting physical exercise along with diabetes and inotropic agent. Dizziness, tachycardia due to POTS can be managed with fludrocortisone, midodrine, desmopressin, and metoprolol. Headache due to dysautonomia can be treated with adequate hydration, increased salt intake, and analgesic. Stroke management, according to the type of stroke, in ischemic stroke, statins and antiplatelet are the main stem of treatment, along with physiotherapy and control of risk factor. Anti-epileptic like valproic, phenytoin sodium, levetiracetam can be used in case of seizure disorder along with precipitating factor. Sleep disorder management includes maintenance of the sleep hygiene. Sedative hypnotics may be used for inducing sleep like alprazolam, melatonin, mitrazepam has got role. Anxiety management, patient has to be asked to stop watching the news about the pandemic, take up meditation and yoga regularly, stay connected with friends and family, and anxiolytic like alprazolam and etizolam has got role in management of anxiety. In depressive patient management, psychotherapy and counseling has got role, very important role, along with antidepressant medication, which can be used with psychotherapy. Brain fog can be managed with pharmacological management like atomoxetine, amphetamine, methylphenidate, and modafinil. Following COVID infection and during infection, we are getting more number of stroke, encephalitis, Guillain-Barré syndrome, coronary artery disease, diabetes mellitus, thyroid disorders, renal failure, along with neuropsychiatric manifestation in OPD as well as indoor. This is one case report in case series because of post-COVID Guillain-Barré syndrome published from our department in month of May. In conclusion, I'd like to share symptoms do improve over time and long-term follow-up is required for diagnosing and management of post-COVID ailments. Integrated holistic rehabilitation approach is best to this group of patients. Assurance, reassurance, reassurance to the patient and family members is need of the hour. These are various social organizations all over the world helping the long COVID patient. This helpline numbers belong to Sambalpur. Thank you very much for patience hearing.
Thank you, ma'am, for the brief talk. We go over to our next participant. She is Dr. Tazma Afzal from the Department of OG. Please share your slides. Malti, ma'am, please stop share. Okay. Over to Dr. Tazma Afzal, the youngest in the group amidst all professors. Please carry on.
Thank you, Sharmishta ma'am, for the introduction. Respected organizers, Dean ma'am, Director sir, all the eminent speakers and panelists, a very good evening to you all. I am Dr. Tazma and my topic today will be challenges in the management of pregnancy in the COVID-19 era. Let us see what are the effects COVID-19 has on a pregnant woman. There is an alteration of immune system that causes immunosuppression in pregnancy, and coupled along with this, the physiological changes in pregnancy, these certain viral infections are worse in pregnant women. However, NICE in 2021 stated that pregnant women are not more susceptible to the consequences of COVID-19 versus the general population. Those pregnant women who have comorbidities are at a higher risk of critical disease. These risks can be obesity, background risk factors, renal diseases, heart disease, diabetes, hypertension, asthma, immunocompromised states like HIV and blood dyscrasias. We should also take care about addressing the mental health issues among the pregnant women amidst COVID-19. Because of excessive social media messages, worrying about infection control procedures, being isolated from friends and family, the pregnant women have a lack of sleep, they are anxious, easily irritable. This not only causes an effect on the mother, but also on the growing fetus. The long-term impact in pregnancy, that is post-COVID sequelae, is yet unclear. However, RCOG in 2021 did a meta-analysis wherein studies showed that severe illness is more common in the later half of the pregnancy, that is in the third trimester. More than 2/3 of the women who have COVID are asymptomatic, while 5% require critical admission. The symptoms which pregnant women experience are not different than what a non-pregnant population, that is a general population, experience. The ranges of severity of illness, as already said by Dr. Kothas early on, ranges from being asymptomatic to mild infections, moderate infection, severe and critical infection where they may have ARDS, multi-organ failure and sepsis. Let us see the effects of COVID-19 on fetus. Canadian Medical Journal in March 2021 stated that the consequence of COVID-19 on fetus is preterm labor, low birth weight, stillbirth. However, larger studies are required to understand whether it is iatrogenic because of fetal condition or because of maternal indications, or it is spontaneous because of COVID itself. There is no data suggesting increased risk of miscarriage or early pregnancy loss. There is no evidence yet of teratogenicity, no evidence of vertical transmission. Currently, COVID-19 in mother is not an indication of termination of pregnancy. Apart from the usual modes of transmission, that is via droplets, via direct contact with the COVID positive patient, or by fomite infection, vertical transmission is uncommon. Also, COVID is not spread by the mode of birth, delayed cord clamping, skin-to-skin contact, method of feeding, and rooming in. Let us see how antenatal care needs to be done. WHO very early on stated that before, during, and after childbirth, all women have the right to high-quality care. This includes antenatal and intrapartum care, newborn care, postnatal care, and also care of the mental health to prevent the woman from having postpartum psychosis or depression. For this, an adequate preparedness of the obstetric unit is important. Appropriate isolation for suspected or COVID-confirmed pregnant women, a basic and refresher training for all the healthcare personnel regarding as to donning and doffing of PPE and also infection control practices, sufficient and appropriate PPE at all points of care. Care should also be taken to prevent infection to the newborn, to prevent severity of infection in the mother, and to also prevent spread of infection from the patient to the healthcare provider. In this COVID-19 era, for non-COVID pregnant women, WHO suggests 4 antenatal visits, that is at 12 weeks, 20 weeks, 28 weeks, and 36 weeks. In these visits, they should shorten the duration of contact, limit the number of accompanying persons. Also, for those patients who have high risk like preeclampsia, gestational diabetes, or any heart disease or renal disease, they may require frequent visits, which will be individualized for these women depending on where they stay. Also, it is imperative to continue to provide necessary prenatal care or antenatal surveillance. Telemedicine has become a very important tool in COVID-19 pandemic to met out pregnancy-related services both antenatally and also for postpartum. Antenatally, virtual prenatal visits, home monitoring like blood pressure, fetal monitoring, blood sugar monitoring, weight, consultation with maternal fetal medicine specialists, genetic counselors, for also mental health care experts. This communication can be provided online. Also, in the postpartum period, lactation support and virtual postpartum visits can be conducted. Coming to the advice to pregnant women, apart from the usual dictum of prevention of COVID-19 measures, which is usually advertised, we should also advise regarding diet and hygiene, to stay at home as much as possible, to work from home if possible, to minimize all non-essential interactions with family and friends, to minimize travel. If travel has become necessary, then to use a private vehicle. Also, to use the phenomena of shielding. This is a phenomena in which pregnant women with high risk factors are to stay at home and to avoid all contact with family members as much as possible. This is a flow chart which has been taken from Lancet that is now accepted by RCOG and by FOXI to help in treating pregnant women who have had a SARS-CoV-2 exposure, depending upon the clinical examination of the woman and the RT-PCR reports. If the patient is asymptomatic, she can be monitored at home till her test either comes out to be negative, wherein she can be stopped monitoring. If her test comes out to be positive, she can be isolated at home for 14 days and ultrasound fetal surveillance for growth and Doppler. Also, antenatal checkup should be conducted 2 weeks after she has been confirmed COVID positive till she recovers. If the patient is symptomatic after contact, or travel within the last 14 days, monitoring at the hospital should be done. She should be placed in an isolated room and protective gear should be donned for her care. If she comes out to be negative, she may be sent home for clinical self-monitoring, and if needed, an RT-PCR test should be repeated. However, if she comes out to be positive, she should be immediately sent to a COVID-specific hospitalization in a tertiary care center, wherein all facilities for maternal surveillance and fetal surveillance are available. Depending upon her symptoms, if she has respiratory symptoms, using the quick SOFA score, she may be admitted in intensive care units. Let us see how intrapartum care needs to be taken care of. The timing of delivery is very important. COVID-19 does not dictate the timing of delivery except in critically ill patients where we think that the maternal respiratory distress may decrease upon delivery. For patients with confirmed COVID-19 infection in third trimester where there is no obstetric indication, it is reasonable to delay delivery by at least 14 days. That is to say that the timing of delivery should be based individualized on clinical stability of the mother, period of gestation, fetal condition. RCOG recently stated in March that just upon doing a cesarean section and delivering the baby does not help in decreasing the respiratory distress of the mother. For this, other measures need to be taken. The mode of delivery is also not to be influenced by the presence of COVID-19 infection, unless the woman's respiratory condition demands urgent delivery. The decision is based on obstetric, that is fetal and maternal indications, and not on COVID-19 status alone. During labor, apart from the maternal statistics like temperature, respiratory rate, oxygen saturation, pulse rate, and BP, the fetal monitoring should be done as usual, that is cardiac tachography monitoring for the fetal heart rate and progress of labor using the partograph. Amniotomy and delayed cord clamping should be offered to the mother because WHO in its studies does not states that it is highly unlikely for the COVID infection to be transmitted from the mother to the fetus by doing these procedures. So amniotomy may be used for progression of labor, and delayed cord clamping should be used as part of third stage management. Coming to whether anesthesia can be used, general anesthesia is usually avoided because not only it is an aerosol generating procedure, but it needs to be used with caution in cases of respiratory compromise, which is caused because of COVID-19. However, spinal and epidural analgesia or anesthesia is not contraindicated. Medical management has been dealt with by my predecessors in details. I'll just like to add, apart from the supportive therapy, antiretroviral therapy, there is no specific studies of these antiretroviral therapy being done in pregnant women. So it is to be given following the dictum where the potential benefits outweigh the risks, and only remdesivir is advised these days. Antibiotics are not to be used unless you suspect a secondary bacterial infection. Monoclonal antibodies, also as sir has already told, that it should not be given in ventilated patients or those who have been on chronic oxygen therapy, has to be started early on. However, again, there are no specific studies in pregnancy regarding these particular drugs. Therefore, only when the potential benefits outweigh the risk should these be given. Corticosteroids, dexamethasone is a stay of therapy, and thromboprophylaxis. Low-dose aspirin, which is usually given in pregnancy because of preeclampsia, there is no change in recommendation. Neither there is a change in recommendation in the administration of corticosteroids for fetal lung maturity. Magnesium sulfate, which is prophylaxis, can be given as 4-gram bolus dose. However, it should be balanced against the risk of respiratory distress. Thromboembolism is more commoner in pregnancy because of reduced mobility. Moderate and severe COVID infections may cause it. Pregnancy is a hypercoagulable state as such, and other risk factors like preeclampsia may coexist. In this case, thromboprophylaxis is offered to all pregnant women who suffer from moderate to severe COVID infection. It is also seen that COVID-19 infection leads to thrombocytopenia, wherein the platelet count of the women falls to less than 50,000, wherein thromboprophylaxis has to be stopped. Thromboprophylaxis is offered to all pregnant women with confirmed COVID-19 infection, moderate to severe infection, offered for 7 to 14 days, unless delivery within 12 hours is imminent or patients have a history of hemorrhage. Low molecular weight heparin is preferred. However, unfractionated heparin may also be used. It is also offered 10 days following discharge in patients. Coming to postnatal care can either be done at the home of the patient, wherein we can utilize the ANM workers or ASHA workers. It can also be done by asking the patients to come to a clinic wherein the infection rate is reduced, also via virtual appointment through telephone or video links. Postnatal care is to be done for 8 weeks postpartum, wherein contraceptive advice, self-isolation for 14 days, diet, hygiene, care of the baby, danger signs and symptoms of deterioration should be told to them. Breastfeeding advice is important as well. Women with COVID-19 can breastfeed if they wish to do so. There is no contraindication for it. However, they should maintain proper respiratory hygiene, wear a mask, should not sneeze or cough on the baby. They should wash hands before and after touching the baby and routinely clean and disinfect all the surfaces. If, however, a woman with COVID-19 is too unwell to breastfeed, she may use expressed breast milk or relactation after she feels better, or donor human milk may also be used. Coming to the latest and hottest topic of vaccination, evidence now in March, FIGO has accepted and showed its in study that vaccination can be given to all women of any gestational age and to the lactating mother. Counseling is very important. It needs to be done to tell the mother how vaccination is going to help her and about side effects like fever, mania, which she may have after she takes the vaccination. Both Covaxin or Covishield may be given. However, FIGO and Foxy have agreed to it that Covaxin is usually preferred in high-risk patients like those who are having preeclampsia or heart disease. TD vaccine and Covaxin can be given at the same date. However, it is preferable if they are given 14 days apart. Anti-D vaccine in Rh negative patients and COVID vaccine can be given at the same date, however, on two different sites. Like all general population, interval between two doses is same, and if the mother is COVID positive, the vaccine has to be deferred for 3 months. Vaccination in breastfeeding women is proved to be beneficial because vaccine stimulates the synthesis of immunoglobulin A, which passes through the breast milk and may provide some kind of protection to the neonate as well. A woman who is breastfeeding can take vaccine. She need not stop breastfeeding for a little while also after it. Women planning pregnancy can take vaccine and I would like to add over here, as the rumor goes, vaccine does not cause infertility. Routine testing for pregnancy before vaccination is not recommended, and there is no need to postpone pregnancy after receiving the vaccine. My take-home message will be, the pregnant women are not more susceptible to COVID-19 infection as compared to the general population. However, in the presence of comorbidities, they have an increased chances of having a critical illness and hence increased ICU admissions. The symptoms, signs, and laboratory testing using RT-PCR or rapid antigen test is similar to that of non-pregnant population. Adequate preparedness in the obstetric unit is very important to tackle this. Also, infection prevention practices are to be strictly followed. Breastfeeding is safe. Vaccination to all pregnant women at any trimester. Thank you.
Thank you so much, Dr. Tasma. Our final speaker would be Professor Dr. Sadhu Charan Ponda, sir. Sir, please share your slides. Please bear with us since we are covering many disciplines and time limit is less. So at times our speakers speak for a little extended time. So please bear with us. Over to Sadhu, sir.
Visible?
Yes, audible but not visible, sir. You have to share your slides, sir.
Should I go again? Oh. Share koli, tapore. Acha, just yes.
Yes, sir.
Visible now?
Yes, sir.
Okay. So, welcome to this academic night dedicated to updates of COVID-19. All dignitaries, esteemed speakers, discussants, and all other listeners. See, pandemic, as you know, this corona pandemic, the virus is new to all. And the challenge to mankind is the expertise and human values also. And the strategies are 5-pronged strategy. There is 3T: test, track, treat, for COVID appropriate behavior, and vaccination. And the ultimate challenge is VVIP, that is vaccine, variant, infodemic, and P for person, politics, and performance, and so many things. So now, you see, you know about the types of vaccines, which I am not touching upon. So there are so many types of vaccine, mainly this mRNA vaccine, DNA vaccine, viral vector vaccine, then whole cell inactivated vaccines. So when these vaccines are given, how the performance should be measured? When the performance of the vaccine is measured in ideal condition, then it is called efficacy, and it is measured in the community, wider population, that is called effectiveness. Say, it is calculated here, placebo group, vaccinated group is taken, and suppose there is 80% reduction, that is 80% efficacy. What does it mean? It doesn't mean that once, it does mean that in a vaccinated population, 80% fewer people will contract the disease when they come in contact with the virus. It doesn't mean that the vaccine will only work 80% of the time. So a person's risk of getting the disease decreases by 80% after vaccination. So with this backdrop, let us see this structure. This is the spike protein, and all the vaccines, the whole aim is to produce this spike protein through mRNA, through DNA, or through viral vector. That is the ultimate aim, except this whole cell inactivated vaccine. Professor Roth, he told about these structures touched upon. So here in this RBD, receptor binding domain, or SE2, here also is a target for drug and also target for vaccine. And here in this S2 domain, this HR1 and HR2, here also there is a target for drug and vaccine, that is the immunogenicity, or it is related to the antibody. So this, when here slight change, a deletion or replacement of amino acid is given, then it affects this viral entry, and then attachment to the cell, or the infectivity and immunogenicity. Everything changes. So on this backdrop, you see the original virus, one virus, there is a lot of change now. So during the process of replication, there are so many errors, and few errors that, as you know, it is called mutations. So they are overlooked, and this virus, with the help of an enzyme, it proofreads. So that's why the mutation is slower than influenza virus. So anyway, the four major variants of concern are this alpha, beta, gamma, delta, and delta plus is raising its fangs, but delta is now dominating, not only dominating India, it is also dominating gradually to other countries. So here the vaccine efficacy and effectiveness. First thing, all these companies or the vaccine producers, they have different type of vaccines, and their modalities, methodologies, the people included, and the timing, everything actually affects the efficacy. Here you can see, these are the efficacy in the, means this is a controlled trial. Under this controlled trial, you see Pfizer having 95% highest, and Johnson & Johnson 66%. This is the efficacy. And Covishield 70%, Covaxin 77.8%. And here you can see against these variants, alpha, see it is less than this, and Moderna is 100%. And here, so many types you think, but here, as far as Delta variant is concerned, the efficacy of Pfizer or the mRNA vaccine of Pfizer, you see the Israel study, it was in the January to March, it was 94%. But in July, it came down to 64%. So that's why Pfizer already is trying to think of giving a booster dose. And they have made a trial and they have got promising results. So here, what I mean to say is, this efficacy is not done on different parameters, say to prevent infection, against symptomatic, against asymptomatic, against mild to moderate disease, against severe critical disease, against hospitalization, and against death. And overall efficacies are this. So more or less, all these vaccines are able to protect against hospitalization and death more than 80%. And say like Pfizer and Moderna, Sputnik V is 100%. So here I can give you how this timing and all affects the efficacy. See, Moderna and Pfizer, this where the trial was taken in USA, conducted when the cases didn't reach a peak. When Johnson and Johnson, the trial was taken, conducted, then the cases reached the peak already. There is a huge rise of cases, COVID-19 cases in US. And when the Johnson and Johnson, they had a trial at South Africa, and at that time, the beta variant, that is the South African variant, was dominant. That's why the overall efficacy was 67%. So, you see, for head-to-head comparison of vaccines, it is very difficult to compare because the timing, the inclusion criteria, and all these things vary. So now, besides this efficacy, then there is another important thing that is called the correlate of protection. Correlate of protection means, say, when we are giving a vaccine, we know antibodies are formed. But again, the antibodies are of two types. One is binding antibody, another is neutralizing antibody. Binding antibody only binds, it may kill, but the primary aim is to bind the antigenic cell. The cell presents the antigen and the antibody binds. But the neutralizing antibody, it kills the infected cells. That's why the proportion of neutralizing antibody is counted in different various mechanisms, taking the convalescent serums of the patient and taking in the plate. All these details are there. They count it. But here what happens, you see the chart, you can see when there is a decrease in here, this thing is 50%. So here the neutralization level of neutralizing antibody, in terms of neutralizing levels of neutralizing antibody, the efficacy is set as 50% for both the variants and the original virus. That is one virus or the wild virus. Now, when the vaccine is given to the patients with the different variants, what happens? Says there is a twofold decrease in the neutralizing antibody. That means the efficacy of say 90% comes down to around 35%. Similarly, when it goes down to 10-fold reduction in the neutralizing antibody, then the efficacy goes down to 10%. So that is very important. So when we conduct the trial, whether it is effectiveness trial in the community or efficacy trial, so there we see the count the number of sick patients and both in the placebo control group and the vaccinated group. So that is a different issue. But when you see in terms of the level of neutralizing antibody, it gives another picture. So here, the fold reduction, here you can see the Covaxin against alpha it is 0, against beta it is 3, and Covishield again alpha 2.5 to 9, again delta it is 2, and Covaxin it is yet to be studied. So here Covaxin and Covishield work against the variant, these variants in terms of neutralizing antibody better than others. Then Covaxin, because it is our Make in India product. So here the overall efficacy is 77.8%, asymptomatic 63.6%, and it prevents symptomatic 65%, and against severe disease 93.4%. So what is the strategy to tame the variants? Increase the gap between dose 4 times. See, more antibody within a gap of 45 weeks than 8 to 12 weeks. You know, this AstraZeneca or the Covishield, they are fond of doing various experiments, changing the interval or gap between the doses. And they have found that after around 10 months, if it is done, then the doses, the antibodies level increases 4 times, then that is given within 8 to 12 weeks, the second dose. Then higher efficacy with third dose. So already the Pfizer, they have started giving a booster dose after the Israel result, that 6 months after, and it is effectively increasing the neutralizing antibody. And actually Germany and one more European country, they've actually started this, giving the booster after 6 months. And then comes the COVID study, that is mix and match the vaccine. What is this? This is called heterologous prime and boost regimen. That means, say, when you are giving, say, viral vector, adenovirus viral vector, first dose and also second dose, when the first dose is given, there are two types of antibodies are created against the viral vector vaccine, against the spike protein and against the adenovirus itself. So when the second dose is given, the carrier, the adenovirus is the carrier. So antibodies are already produced and during the first dose. So it will remove or kill the adenovirus vector which carries the spike protein. So definitely the result is the efficacy will be less, or the level of neutralizing antibody will be less. So to combat this, they have experimented with, say, one AstraZeneca viral vector, then Pfizer. And what it gave? So here high level of protective antibody also was achieved, and the T cell response was also better. So this thing is called heterologous prime and boost regimen, and it is going to be applied in HIV vaccine, TB vaccine, and also for some cancer vaccine. So many vaccines already it has been started. The experiment has been started. So vaccine efficacy above and beyond. What else now? There is a need of a booster. Everybody realizes, and updating vaccines with spike protein of variants. So here, Pfizer has already included the spike protein of the Delta variant. And as such, the spike protein of the Pfizer or Moderna, they are stabilized. That is, at the HR1 and HR2 domain of this S2 protein, they have added two prolines, that is called S-2S, 2P. So when they have added two prolines, it has been more stable. And again, they have added 4 more additional amino acids, that is called hexapro. That makes the spike protein more stable. That means those spike proteins which are made through mRNA in the human cell, the more spike proteins are created and they are stable. And once they are stable means the antibody production will be also better. Then the second generation of viral vector vaccine is also coming up. That is, there are certain viral vectors, they are coming up with production of spike protein as well as nucleic acid, right? And last is updating vaccine in line of flu vaccine. You know, northern and southern hemisphere always the tracking is done about the change in the strain, antigenic shift and all of the flu vaccine, and accordingly flu virus, and accordingly new vaccines are prepared, and for which no trial is also required. But they are thinking if the situation will arise, we have to update the vaccine, COVID vaccine. So it requires tip-top efficacy, but the question is how, when, and how often. If multivalent, whether the trial is required, but because it is a new virus, the trial, if trial is required, the delay is, question of delay is also there. And response to new vaccine by people vaccinated earlier, we don't know what will happen. These are certain questions which actually haunts the mind of the scientist. So ultimately, we should play whack-a-mole and chase the variant, or you can try to go ahead of them. And there is no option with us to tame these variants of SARS-CoV-2. So the key message is, you see, the goal of the vaccine efficacy, goal of COVID-19 vaccine is not to eliminate the virus, but to remove its ability to cause serious hospitalization, death. If we'll take vaccine, at least we'll, if at all we are infected, we should feel like getting just a common cold. That is the end. And so which is the best vaccine for us? irrespective of all this efficacy business, the one that is available to us. And the key message is, V will prevent V and bring V. Vaccine will prevent variant and bring victory to us. So, मानो तो जिंदगी न मानो तो मौत की साया, जीना है हम सबको, ये आफत से बला से निजात पाना है, नसीहत अमल में लाने के लिए तकलीफ तो उठाना है। कोविड के पूरा टीके, 2 टीके नहीं, some vaccines are having 1 dose, so कोविड के पूरा टीके लेना है अगर हम सबको कोरोना को हराना है, Thank you.
Very well said. Very well said, sir. Thank you so much. Over to our director, sir, to sum up the various disciplinary talks into a small compile of take-home message. Over to you, sir.
So at the outset, I must thank all the speakers for the wonderful job they have done. Really, all of you are now loaded with all the information. I don't know how much you are going to receive from me, but still I will give some information to all of you, along with some important point that I will tell in the summary. So straight going to the management actually. What has been the change? Why are you discussing it? Why are you updating it? That is the main motto for which this has been done. So coming to the management of mild case of COVID-19, what was there, what is there, and what is going to happen? There are differences in different guidelines that one has to know. Unless somebody goes through all the guidelines, anybody will be confused. What is there in our Indian guideline now for mild cases, apart from the symptomatic management? Now still in last, or you can say the recent guideline that was updated in May by the government of India, still we have ivermectin or hydroxychloroquine. But so far as the other guidelines are concerned, like WHO, IDSA or NIH, this is out. There is no place of these two drugs in management of mild. Even to talk of favipiravir, nowhere it is mentioned in no guideline, neither Indian guideline, nor ICMR guideline, nor NIH, nor IDSA. So, and why all these things have happened, actually, if time will permit, we can discuss. But then what has been the change? Really, the change is very, very important change that has occurred in the management of mild cases. That is the introduction of monoclonal antibody against the spike protein. So there are 3 already Professor Rath has told. One is the combination of casirivimab and imdimimab at a dose of 600 plus 600 milligram, or sotrovimab at a dose of 500 milligram. Another antibody cocktail is the cocktail of etesevimab and balminicimab at a dose of 700 plus 1400. These are the 3 regimens. Out of these 3, the most important one, or the most commonly used the monoclonal antibody, is the cocktail of imdisivimab and casirivimab, which was administered to president, the past president of USA, and from that it has gained attention. After that, a lot of attention was given to this molecule. And this is indicated in mild case when there is a condition of progression of the disease, like elderly more than 60 or 65, obesity, diabetes, hypertension, ischemic heart disease, presence of chronic lung disease, chronic liver disease, and so on, that Dr. Rath has already enumerated. This is the indication. And presently, patient not on oxygen therapy or any other supportive measures. This is the indication. But now again, probably in future, this indication is going to be changed, because there has been a trial and the interim results are, even in patients with moderate disease who are on low oxygen flow, there has been encouraging result. And the result of this casirivimab and imdimimab is protection of the death rate is to the tune of 70%, and about the sotrovimab and the balmilimab is about 85%. So it is going to be the game changer. But what is the limiting factor? The limiting factor is the price for all of us. Then coming to the management of moderate to severe case, the principle is oxygenation. Here the target should be, now ordinarily it should be 90 to 96%. If the patient is pregnant, it has to be 92 to 96%. If it is a COPD, make it little less, 82 to 90%. And it can be administered by face mask or by nasal cannula or by reservoir bag
क्वेश्चन मुल्ले पठेइतले हेटा के टाइप करके दिल्ली
or high flow nasal
मुझे नहीं
cannula, or later on if it cannot be managed with high flow nasal cannula, then you can put an NIV, and when it cannot be maintained with NIV, then you can subject the patient to in mechanical ventilation, and once mechanical ventilation fails, then we have to resort to ECMO. Then coming to other drugs therapy like anti-inflammatory drug, anticoagulant, and other immunomodulatory therapy. Among the anti-inflammatory drug, now steroid has a very, very prominent role and a definite role to play. What is the reason behind it? The steroid, there has been a meta-analysis of 7 trials, where out of which the most important trial is the recovery trial, and the other trials are the REMAP-CAP, the CODEX trial, glucovit trial, and so on, like that, where dexamethasone, hydrocortisone, methylprednisolone, all these steroids have been given. And all these meta-analysis show a definite and conclusive evidence that we get a benefit so far as the mortality is concerned, and so far as the need to ventilate support is concerned. Hence, the role of steroid has become very, very important. Then question is, what steroid you are going to give, when you are going to give, how much you are going to give, and what precaution you are going to take. These are very important things. And already it has been emphasized, it has to be given after 7 days, because if you give before 7 days, there is a possibility of prolonging a viremic phase. Then what steroid you are going to give? Are you going to give dexamethasone or methylprednisolone or hydrocortisone or what else? All these meta-analysis of the 7 trials have told whatever you give, the results are same. Hence, there is no question of choosing whatever is available, you can give it. Then what precaution you are going to take? The most important precaution is there is a possibility of glucose excursion, especially more in diabetes and even those who are pre-diabetic. So take care of the glucose excursion. Otherwise, again, you'll end up in complications like DKA or important complications like mucormycosis that you come across. So here the intensivist, role of intensivist is very, very important, or the doctor who is taking care of the patient, because the glucose monitoring becomes very, very essential. And if necessary, we may have to resort to glucose insulin infusion to control the hyperglycemia. Then coming to the role of antiviral drug, remdesivir is the only drug which has been approved by FDA, but of late now it is not being favored by many professional and professional bodies. Even in India also there is some recommendation with some reservation similarly by the WHO. The reason being, the efficacy of remdesivir was evaluated initially by the ATTACK trial 1, in which it was shown that the recovery period, or you can say the hospitalization period, was certain. It was 10 days versus 15 days. If you give remdesivir, the recovery rate will be 10 days approximately, in contrast with 15 days if, of the placebo. That was the only benefit. But after this, the WHO has conducted a very landmark trial that is called Solidarity Trial in March 2020, where they have made 4 groups of patients. One group remdesivir, another group chloroquine or hydroxychloroquine, one group remdesivir plus interferon beta, and another group they have given lopinavir and ritonavir, and they have conclusively proved that all these 4 groups of drugs are not superior to placebo. That is very important message, and after which this use of chloroquine and hydroxychloroquine has been almost totally abandoned by the WHO and many other countries. Then coming to the anticoagulation therapy that already has Dr. Pothal has told, we must remember we have to give only prophylactic dose of anticoagulant unless we deal with a case of pulmonary embolism, which occurs usually in ICU patient subsequent upon deep vein thrombosis. There you can give the therapeutic dose. That means double the dose. So if you are giving low molecular weight heparin, it has to be 1 milligram per kg subcutaneously twice daily. That means the half of that of the will be prophylactic dose. Then coming to other drugs, another recent and important change has been the use of IL-6 receptor antagonist, that is tocilizumab. It has, and WHO has strongly recommended, that is very important to know, WHO has strongly recommended the use of tocilizumab. Why? It is the result of meta-analysis of 3 important trials, that is the recovery trial, roadmap trial, and another is impact trial. All these 3 trials have clearly shown that the need to ventilation is less, mortality is less, duration of hospitalization is less. Hence, it is strongly recommended. And we have got 2 important drugs in this IL-6 receptor antagonist, the tocilizumab and sarilumab. The number of studies with sarilumab are less, hence this tocilizumab is most favored. And you know the dose is somewhere around 400 milligram, max you can give up to 800 milligram. Then coming to other drugs, another important drug which has also got DCGI approval, emergency authorization approval, is the JAK inhibitor, that is baricitinib, and it has to be given along with remdesivir, not alone. And this has been proved by COP barrier study that it has got a definite advantage of reducing the mortality. Hence, the baricitinib is also nowadays favored, but you give either tocilizumab or baricitinib, not both the things. Both the things are not favored. And while giving baricitinib, you keep an eye on the LFT, KFT, as well as the emergence of or reinfection of bacterial infection or fungal infection. These are the important things so far the drugs are concerned. Then coming to the other complications of COVID, the 2 new important complications that we have come across now is the post-COVID syndrome, which was beautifully explained by Dr. Malti Murmu. That means many of the patients, they do recover after 4 weeks, but still some symptoms and signs, they continue. They experience some symptoms and signs pertaining to each and every system. You can say anything, it can happen beyond 4 weeks. So you can tell it is post-COVID syndrome, and few authorities also tell it once it persists beyond 12 weeks, then you tell that they are post-COVID syndrome. It can affect any system. Remember, but the fatigue, fever, myalgia, arthralgia, they remain the most important thing, apart from the mental symptom like anxiety, depression, cardiovascular manifestations, neurological manifestations like LGB, myelitis, encephalopathy, etc. Even the renal, all the systems can be affected, and the management is largely symptomatic. Then another interesting complication that has newly, or you can say entity that has newly come up, is the miscellaneous or multi-system inflammatory syndrome of the children, which has been beautifully presented by the Professor Prakash Panda. This is nothing but the new syndrome which occurs in children, usually after 2 to 4 weeks of recovery of or the onset of infection of COVID-19. And the diagnostic criteria is persistent fever, more than 100.4 degree Fahrenheit, at least for 3 days, along with at least involvement of 2 major organs, like let us say, for example, mucocutaneous rash or non-purulent bilateral conjunctivitis, presence of shock, presence of hematological manifestations, or presence of cardiovascular manifestations like pericarditis, myocarditis, decreased LV function, or valvular involvement or coronary artery involvement. Then involvement of GI tract like abdominal pain, vomiting, diarrhea, the coagulation abnormalities like increased PTA, PTT, or elevation of the D dimer, and so on. So any 2 system, if you get affection, you can say that this is multi-system inflammatory syndrome of the children, provided there is elevation of the markers of inflammation, provided there is no evidence of bacterial infection to account for it, provided there is evidence of any kind of evidence of COVID-19 infection. That means you should have a temporal relations, either the present documentation of antigen positivity or RT-PCR positive or positive this thing antibody, or history of linkage, or you can say contact with some positive patients. These are the criteria for diagnosis of this thing, multi-system inflammatory syndrome of the children. The basic management being methylprednisolone is the anchor of treatment, and number 2 is the IVIG. And if they do not improve with this dose, the usual dose, you can increase the escalate the dose of methylprednisolone or repeat the dose of IVIG. And after they recover, what is most important is to put them on aspirin. Then this is all about, you can say, the important new entity that has emerged after this COVID. And to tell something about the vaccinations, I think Professor Sadhu Charana Panda has given a very detailed description of these vaccines. Now we have got a number of vaccines like the Pfizer, Moderna, AstraZeneca, and Covishield, Covaxin, Johnson and Johnson, and Sputnik V, and so on, and the efficacy ranging from 66% to 95%. And we hope we will be able to fight this epidemic with the help of these vaccines. Once everybody accessible to this vaccine, now we'll be in a better position to fight this epidemic. But I will say, still, we have to be in search of a very, very important drug which will act against the virus. That means an antiviral drug which can be very effective, safe, which can be given orally, and which has to be affordable. Then only we'll be in a very comfortable position. So with this, I thank you all again for your patient listening to my concluding remark. Thank you all very much.
Thank you very much, sir, for that vivacious talk. Any other panelist or discussant would want to say something? Please. Our discussants or panelists. Prabhati ma'am, would you like to say something?
Basically, we know that COVID-19 disease is immunogenic and thrombogenic, involving micro and macro angiopathy. So, lung is the primary attraction for COVID-19. And in severe cases, Director Sir has very wonderfully summarized the today's topic. And I want to add one thing. In severe cases, those who need longer oxygen requirement, they are having lung fibrosis. These are acute lung fibrosis due to COVID-19 disease. But the antifibrotic drugs we use in chronic PF-ILD, that is progressive fibrosis in ILD. So in acute COVID-19 ILD, what happens? The inflammatory markers are same as seen in chronic fibrotic lung disease. So we can use antifibrotic, those who are in need of oxygen for longer period, and it is useful, and so many literature supports in favor of that. That's all.
Thank you, madam. Subudhi sir, are you there, sir? Hello. Anybody else who would want to say a few words?
You can take up few questions and then you can wind up. I think it's already too much delay.
The questions have all been answered, sir. Only 2 questions remain, and that is to Bimal Ponda, sir. I think he has also answered. One of them is when to decide to stop prone position ventilation. Can anybody answer?
Yeah, I have already.
Please say, sir.
Yeah, I have already answered. The prone ventilation, I have written it, that whenever there is decrease in PA to FiO2 ratio of less than 150, at that time we plan for prone ventilation. When with FiO2 of 0.6%, with PEEP of 5, we are unable to maintain the saturation, at that time, we plan for prone ventilation for up to 12 to 16 hours. This is the recommended guideline presently.
Yes.
So that's how we plan prone ventilation. When, despite of our conventional ventilatory strategy, we don't have the required saturation level maintained, and we have acidosis. At that time, we restrict to prone ventilation. Another question was there, which you told me, because I didn't find anything in the question answer section, that which type of ventilation we should use. Actually, it is volume control ventilation with pressure limitation.
Yes.
Reason is we have to give a fixed amount of ml of tidal volume. That much amount of tidal volume, we have to see that the pressure doesn't move beyond 30 of plateau pressure. So we have to limit the pressure. So we have to give a volume control with a pressure preset. That is assist control ventilation.
Thank you, sir. Thank you, sir. And we had a discussion of 7 disciplines, very vivid talks, followed by a very good summary by our director, sir. I think we should conclude our talk now. I would request Sunanda ma'am to give a vote of thanks. Sunanda ma'am, please unmute yourself. Please unmute. See on your screen that red mark is there, you just touch it, it will unmute. Sunanda ma'am, can you hear me?
I think she's not there, right?
She's there.
Madam, it was very nice you have conducted.
Yeah,
so,
no, I think
and
you
as
don't need any thanks.
And
I think on behalf of everyone, I will thank you that you have organized it, and so nice actually. Once again, thank you all, very speakers.
She's there.
Thank you so much.
Let us.
Thank you, sir. Thank you, sir.
Okay, she's there.
We should be thankful to our Dr. Das, Gunasagar sir.
Yes, sir.
The source has started from the Sagar, the inspiration.
Sir, actually, this was a tradition in Burla to mix up 2 or 3 departments on subjects. During my PG period, Dr. R.N. Sahu was there, he started this. So let us continue in Bhimsar. Last but not the least, I want to thank the Sinopia people who gave us this platform to hold this webinar. Puneet Jain, Chandan, Praful, and Ajay. Thank you, sir.
Thank you, sir.
Thank you, one and all.
So, with your permission, can I end the meeting?
Yes, sir.
Thank you.